Good morning, good evening, good afternoon. We are going to discuss today the hot topic from the ASH 2024 with the focus on graft versus host disease as part of this new IHH initiative. As you may know, we have a lot of very exciting data that were presented at the ASH meeting in every disease, in every old field of hematology, and it was also the case for graft versus host disease. This is why we decided to have this webinar dedicated to this tonight. So I will start by the prophylaxis, then I will move to the treatment of acute, and at the end, I will discuss the treatment of chronic graft versus host disease. So regarding the prophylaxis, as you know, over the last decade, the use of post-mortem cyclophosphamide has been associated as the new standard for the prophylaxis in patients that receive stem cell transplantation with an haploidentical donors. In addition, we have also some data that show that it was very effective for patients with match-related and match-unrelated donors. Nevertheless, you know that the dose of cyclophosphamide that was used, it was 50 milligrams per kilo per day for 2 days. It was standard, but it may be associated with some toxicity, some infectious events, but also some cardiac toxicity. Based on that, the team tried to decrease the dose of cyclophosphamide that was used, and it was the case in the study published by Abedin and colleagues, where they use a reduced dose of cyclophosphamide, reduced by 50%, 25 milligrams per kilo per day for 2 days, day plus 3 and day plus 4. It was combined with cofenat mofetil, that is classic, but also with tacrolimus, but also with ruxolitinib, 10 milligrams per day total dose, which is more unexpected, and it was indeed very interesting. So it was some older patient, more than 60 years, with reduced intensity conditioning regimens, and that have an HLA match donor. So this is now haplo. So here, this is the patient characteristics. So this is some preliminary result, only 24 patients. It was mainly some patients with acute myeloid leukemia and myelodysplastic syndromes with some high-risk disease. And it was a majority, almost all patients have some unrelated donors, and 2 of them have match-related donors. And it was mainly some flubu-based conditioning regimens. So here, this is the neutrophil recovery. This is important to look at that because when you are going to give some ruxolitinib after, we need a good recovery to be able to start the ruxolitinib between day 30 and day 16 as it was planned. And in fact, with the reduced doses of PTCy, can also improve the recovery of the neutrophil on the platelet. And as you can see here, we have a median days for neutrophil recovery of day 13 and for platelet on day 12 on all patients engrafted. When we look at the ruxolitinib tolerance and safety, it seems feasible since almost all except 1 patient were able to start ruxolitinib at a median of day 35. So it was in the early range of what was expected. With median number of neutrophil at 3,800 and also a good platelet level when they start ruxolitinib. So it was clearly feasible. We can see here that they have to start ruxolitinib in only 1 patient due to neutropenia, and no patients have to start ruxolitinib because of some graft failures. Patients remain in the hospital for a median of 21 days, and regarding the infectious events, grade 2 to 3, it was around 10%. That was pretty low, and this is what is expected for patients that with stem cell transplantation with some bacteremia and CMV disease. When we look at the incidence of grade 2 to 4 acute graft versus host disease, at 10-100, it was 8%. No patients with severe grade 3 to 4 acute graft versus host disease. And if we focus on the 80 patients with the longer follow-up of more than 180 days, 2 of them developed chronic graft versus host disease, and 4 of them they have relapsed. This is also what is expected. So overall, it seems that in older adults that receive an HLA match stem cell transplantation with the reduced intensity conditioning regimens, PTCy at the reduced dose combined with ruxolitinib low doses is safe and feasible and is associated with a low incidence of severe graft versus host disease, and really need to have some more data with higher, with more patients to confirm those results. Now we are going to move to the acute graft-versus-host disease. So here it was a study that were presented by Rob Zeiser regarding the safety and efficacy of GLP-2, that is a glucagon-like peptide analog, abraglutide, that was used in patients with steroid refractory GI acute graft-versus-host disease, and it was combined with the best available treatment. So it was a second-line treatment, patient with GI acute graft-versus-host disease that failed steroids, and that were included in these treatments to receive the abraglutide combined with some best available treatment. And the best available treatment, in fact, was ruxolitinib. That is the only drugs approved in this setting. So it was systemic steroid plus ruxolitinib plus apraglutide that receives the patients. So there were randomizations to compare two doses of apraglutide. It was based on the weight of the patients with some higher doses, depending on the higher rate of the patients. For patients that have a low weight below 50 kilogram, it was a fixed low doses of abraglutide that were given to the patient. It was a non-randomized study with 2 years of follow-up. So here, the inclusion criteria, so patients with GI acute graft-versus-host disease, steroid resistance, and that receive glucocorticoid plus ruxolitinib for a maximum of 5 days before randomization. So we can start ruxolitinib second line, and after to include the patient to use apraglutide combined to the ruxolitinib. Of course, patients that were in relapse were excluded. So here, this is the patient's characteristics at baseline. So it was, in fact, a major, or almost only patient that have grade 3 to 4 acute graft-versus-host disease. And in fact, it was some patient with severe GI acute graft-versus-host disease, because all of them had a stage 3 or a stage 4 lower GI acute graft-versus-host disease. Here, this is the data on the safety. We have 31 patients that have some treatment emergent adverse events, with 8 patients, 26 that have some grade 5, so that died from these adverse events. But in fact, this is some expected result, because we know that some patients with steroid-resistant acute graft-versus-host disease with GI involvement have some very severe disease, and a lot of patients will have some infectious event that may be fatal for the patients. Regarding the secondary endpoint, that was the overall response rate. At day 28, it was 58%. At day 56, it was 45%. And between day 56 and day 91, it was sustained, since it was 41% at day 91. So it was for all organs. So it was the overall response rate that take also into account for patients that have skin and liver involvement. We also look only at the lower GI response rate. It was 55% at day 28 and 45% at day 56 and day 91. So this clinical trial is still ongoing. In the post-treatment observational phase, we are waiting for more data regarding, in particular, the survival of the patients. But it is some promising data that show that maybe we can combine some treatment with the ruxolitinib to improve the response rates for those patients with some very severe GI acute graft-versus-host disease. We have also some data that I presented at the ASH meeting regarding the use of fecal microbiota transplantations using a pooled microbiotherapy product that is called MAT13. So MAT13, this is a product that is a pool of several donors with a high richness, high diversity, full ecosystems that is stable for at least 24 months at -80, that is given by enema, delivered by enema, that has already been used in a phase 2 clinical study, that is Heracles, that have been published in 2023 in eClinical Medicines. And so far, we have some data on 154 patients, and more than 200 have been treated as part of these compassionate use programs in Europe. What is important with this FMT product is that this is a pool of several donors that allow to have a very high richness and high diversity product. Here, this is the result of the 154 patients treated within the compassionate use program. It was only some patients with steroid-resistant or steroid-dependent graft-versus-host disease, or patient was a GI involvement, any line of treatment. This is not only some second line of treatment. It can be used alone or combined with other treatment, and we must wait at least 12 hours after we stop the systemic antibiotics to give the microbiotherapy product, and patients was not eligible to the ongoing clinical trial RS. I will just say a word right after regarding that. Here, this is a patient's characteristic. They receive a median of 3 lines of treatments, and almost all patients were resistant to steroids. And we have some classic, but we have also 25 patients that have very severe hyperacute graft-versus-host disease, and also some patients that have some overlap syndrome with chronic graft-versus-host disease. Here, this is the response rate for all patients, 154 patients with a day 28 response rate of 51% that was sustained at day 56 being 44%. If we take the overall response rates in all organs that take also into account the liver and the skin, it was 49% and 42% at day 56, and it translates in responding patients in an overall survival of 68% at 1 year. We were able to analyze the subgroups of 58 patients that receive steroids first line, ruxolitinib second line, and MAT13, so the microbiotherapy product as a third line of treatment, and the response rate was better. GI overall response rate was 59% at 1 year, with the majority of complete response at day 28 and 54% at day 56, and it translates into 1 year's overall response rate of 75% in the responding patients. And in fact, this is a population that was studied in the phase 3 RS study. And I am very happy to tell you that we just have, since yesterday, a press release with the result of this phase 3 RS study with all patients that have been included on the response rate that are available. And in fact, we have a very good response rate because it was of 62% at day 28. So this is the same and even higher compared to the patient treated in the compassionate use program, included 30 patients in complete response and 20 patients in very good partial response. So we update you when we have more data, in particular regarding longer follow-up and overall survival in those patients. But the result I show you today in the early access program, I can now tell you that we have the same in the phase 3 clinical trial in patients with GI steroid-resistant, ruxolitinib-resistant acute graft-versus-host disease. So to conclude, MAT13 seems to be very effective in these very severe populations, and we now have been able to confirm this in the phase 3 clinical trial, and we hope that we'll be able to use more easily this treatment in the next years. So now I will move for the next part of my presentation to chronic graft-versus-host disease. So I will start go back a little bit to ASH 2024. You may remember that we have this plenary presentation regarding the use of axatilimab in chronic graft-versus-host disease. And in fact, we have a lot of follow-up data regarding axatilimab this year at the ASH meeting for the treatment of chronic graft-versus-host disease. So axatilimab, I just remember you, this is a CSF1 receptors dependent monocyte on macrophage that mediate inflammation on fibrosis. So axatilimab, this is a monoclonal antibody that will target this CSF1 receptors on the monocyte on the macrophages, and that shows some promising results in those patients with an overall response rate of 67% in the first 6 cycles. So we have the data that have been published in the New England Journal of Medicine by Wolf and colleagues in 2024. It was the data from this multi-center open-label randomized phase 2 study. Just I remember you, it was some patient with active chronic graft-versus-host disease that received some systemic treatment for graft-versus-host disease, more than 2 years, and that receive at least 2 lines of treatment. So 241 patients were included. There were 3 doses of axatilimab, 0.3, 1.0 milligram per kilo, and 3.0, and this is given IV, always given IV, and we have a 2 years follow. And in fact, this year we have Corey and colleagues that were able to present some update response analysis of these clinical trials. And this is what I am going to show you today. So this is a response analysis based on the baseline characteristics. So on the comparison, this is a responder. This is all patients, so 241 patients, and this is a 153 patient that achieves a response. So 153, median age of 52, majority of male, very comparable to the overall cohort. Regarding the prior line of treatment, also very similar to the overall cohort of patients, with the majority of patients previously treated with ruxolitinib, 76% of the patients, 34% that receive ibrutinib, and 20% that receive belumosudil. Regarding the characteristic of the chronic graft-versus-host disease, almost all patients have skin involvement, also the eyes and the fascia, and less patients with the mouth, lungs, esophagus, liver, and very few of them with the GI involvement. We have also a median of 4 organs that were with the chronic graft-versus-host involvement. Overall, when we look at the disease severity, it was also very similar between the patient that achieved the response and the overall cohort of patients. So here, this is the overall response rate. So it was at the low doses, 74% and 63% at all doses. The median time to response was around 1.5 months, irrespective of the dose of axatilimab. And when we look at the Lee symptom scale, that is a way to evaluate the symptom improvement, we see that it was 55% of improvements of the Lee symptom scale by at least 7-point increase, and 48% irrespective of the dose of axatilimab that were given to the patients. So when we look at the time to the achievement of the response rate that is given here, you can see here that we have a median that is less than 2 months, so around 1.5 months. And here, this is also the achievement of the improvement of the Lee symptom scale that is also around 1.5 months. So it highlights that some patients achieve some quick response. As you can see here, the first evaluation was at day 28. This is why none of the patients were reported to have a response within the first 28 days, but we may expect that some of them still respond. Here, this is the organ-specific response according to the NIH, irrespective of the dose of axatilimab that were used in the patients. So for the lower GI, you can see here that we have no response at day 28, but we have some response. It takes some more time at day 56, being 60%. For the upper GI, it was the same. We have more response around day 60. For the fascia, also, we have some improvement in the response rate between day 28 and day 56, and more importantly, at day 84. So it's important to wait more for the patient. This is most of the time some more severe involvement in the fascia, and we need to wait more to see some response in those patients. For the liver, this is the same, better response rate at day 56 and improve at day 84. And for all other involvement, the mouth, the lungs, the eyes, and the skin, we also see an increase in the response rate over time at day 84 and also at day 168, just to highlight that this is important to rate and not to say that the patient fails the treatment and that we can have some late answer. And it is very important because we know that in chronic graft-versus-host disease, we may need now, we have a lot of drug available that we just stop the treatment or start something else. But in fact, we can have some some patient that take some more time to respond. So you must wait at least 3 months before you can say that the treatment doesn't work and that you need to start another treatment. This is true for axatilimab, but this is also true for belimozidil. That is a ROCK inhibitors, or that is used in the similar setting when we have also this response rate that can be seen up to 3 months after we stop the treatments. So regarding the safety, so this is the adverse events. So we have almost all patients that have some adverse events of any grades. We have some more patients with higher doses that have some grade 3 adverse events that were treatment related. Also, it was more frequently with the higher doses of axatilimab. We have 44 or 42 of them that were fat serious in patients that with the higher doses. Again, 35 in patients with the lower doses. And some of them, in fact, were fatal in patients with the higher doses. And we have some more patients that have to stop the axatilimab with the higher doses. That may explain why, at the end, despite the use of higher doses, the response rate was lower. It was because the tolerability was not as good as the lower doses. So patients have to stop the treatment and it may lead to treatment failure. So again, more is not always giving more is not always doing better for the patients. So to conclude, what do they conclude during the presentation in this phase 2 study? The use of axatilimab at 0.3 milligram per kilo every 2 weeks was associated with a high response rate and was well tolerated. We have a median organ-specific time to response that were different, 1 up to 3 months. Fastest response with the GI, the liver, the esophagus, and the joint and fascia. It takes more time for the lungs, the mouth, the eyes, and the skin. The time to the symptom improvement versus organ-specific improvement was faster for the lungs, the mouth, the eyes, and the skin. And it seems that we have a potential for some rapid treatment response and symptoms improvement with axatilimab in this patient with very severe, heavily pretreated chronic graft-versus-host disease. So I just show you the result using this axatilimab, but you know that we have other target for the treatment of chronic graft-versus-host disease. We have JAK2 with ruxolitinib that is approved as the standard second-line treatment in acute, but also in chronic graft-versus-host disease in patients that fail to steroids. And we have this JAK inhibitor ruxolitinib. We have also now the belimozidil that is a ROCK inhibitor that was a first-in-class treatment. I apologize. That is approved in the US and that can be used for an early access programs in some country in Europe. And in the study published, presented by the Chinese team, Zhao and colleague, it was very exciting because they have a new treatment that combined the JAK and ROCK inhibition. It was the rovadicitinib that were used in a steroid refractory or dependent chronic graft-versus-host disease. So it was a multi-center phase 1b/2a study. They included some patients more than 12 years that have a stem cell transplantation, moderate or severe steroid-dependent or resistant chronic graft-versus-host disease that receive at least 1 prior line of treatment for chronic graft-versus-host disease. Here, this is the design of the phase 1b. So the rovadicitinib was given at 10 milligrams, and they plan to decrease if they have some dose-limiting toxicity or to increase to 50 milligrams if there is no dose-limiting toxicity. It was given orally, so this is very important, twice a day. And after, they will do an expansion part with 10 or 15, depending on what have been tested in the phase 1b. And after, there will be also another expansions. So here, this is a patient characteristic, 29 that were treated at 10 milligrams, and after 15 more patients that were treated at the higher doses of 50 milligrams twice a day. So a total of 44 patients, median age of 34. So this is some younger patient, but I remember you, this is some Chinese study. So we most of the time have some younger patients that are treated. A majority of patients with acute myeloid leukemia that receive a myeloablative conditioning regimen, but this is some young patients with some matched sibling donors mainly, or haploidentical donors. Almost all patients receive some peripheral blood stem cells, and we have a median time from chronic graft-versus disease diagnosis to the inclusions of 28 months. So as you can see here, we have some patients that already have a very long story of chronic graft-versus disease before they were included into this study, because there are more than one prior line of treatment. It was not just patient resistant to steroid that were included in this study. So majority of patients have some severe chronic graft-versus disease that were steroid dependent. So when we look more in details into the organ involved, a median of 5 organs involved. So again, some very severe patient. 82% of the patient at least 4 organs affected, a median of 2 previous line of treatment, but up to 7 previous line of treatment. And this is important to point out that 80 patients receive ruxolitinib that already received JAK inhibitors, but none of them receive the belumosudil, none of them receive ROCK inhibitors. So regarding the safety, we have almost all patients that have some adverse event, but again, this is expected in this very severe population. Regarding the grade 3 adverse event, it was 59% of the patients, and we have to stop the treatment because of this adverse event in 7 patients. When we look more in details to the kind of adverse events that were reported and that were related to the drugs, we have some upper respiratory tract infections in 34% of the patients. We have also some pneumonia in almost 1/3 of the patients, and we have the expected cytopenia that may be related to this drug that is also a JAK inhibitor with some neutropenia, leukocytopenia, and anemia. Regarding the overall response rate, so the best overall response rates were very high, being 90% of the patients. And in the 6 months, it was 86% of the patients that achieved a response rate. And at 24 weeks, the response rate was still 66% of the patients. So this is some very promising and exciting result in this very high-risk population of patients that failed, for the majority of them, 2 lines of treatment, and including a lot of the patients that already received JAK inhibitors, the ruxolitinib. The response were rapid, being with 72% and 67% of the patients that achieved a response at 4 weeks, and the median duration of response was not reached. So when we look more in details regarding the organs, we can see that we have some very good response rates in the liver, in the GI, lower GI, esophagus. For the skin and the fascia, to around 2/3 of the patients that achieve a response. And this is more disappointing for the lung, being around 23% of the patient, but this is what is also reported with the other drugs in a similar setting. So this is promising. Really expect to have some more data with an expansion cohort of this study. And in fact, a phase 3 randomized study is now ongoing for adult patients that receive 2 to 5 prior line of treatment for chronic graft-versus disease, and that fail also steroid. They will randomize between rovadicitinib versus the best available therapy, and there will be the possibility at 6 months to have a crossover for the best available therapy to the rovadicitinib arm of in the study. Finally, the last study I would like to present, it is a study by Mo and colleagues regarding the pimicotinib, that is CSF1 receptor. So we go back to the, not the previous, but the presentation right before regarding the axatilimab, that is also a CSF1 receptor that is given IV. Here, this is a CSF1 receptor that is given orally, so have an oral treatment, which is very interesting because we know that it may be difficult for the patient to go back to the hospital every 2 weeks to receive the treatment, and that it, especially for chronic graft-versus-host disease, when this is some very long-term treatment, and that it may be easier to have some orally available treatment as we have with ruxolitinib or belimozidil, for example. So in this study, we have some patients with chronic graft-versus-host disease that receive at least one line of treatment with an ECOG from 0 to 2, that receive also steroids on the calcineurin that may receive also steroids on the calcineurin inhibitors. The pimicotinib was given at 5 and 10 and 20 and then 25, so we increase the dose of the drugs that were given. There will be a part B at 20 milligrams when 27 patients that were treated. So here, this is the characteristic for the entire all the patients. So with the majority of them being treated 14 patients at 20 milligrams. So the median age was 35. We have a median of 4 organs that were involved, and in fact, 60% of the patients have 4 or more organs involved with ruxolitinib, and we have 72% of the patients that previously received ruxolitinib. Only 3 of them received ibrutinib, and 1 of them received belimozidil. So here, this is the efficacy data. So the overall efficacy was of 63% overall response rate at day week 24, so at 6 months. The median time to response was as 4 weeks because we assess the response at 2 weeks and 4 weeks. So the patient seems to achieve a response pretty quickly already at 1 month. The median duration of treatment was of almost 12 weeks, and we still have 29 patients that are still receive the treatment. This is important to look at the patients that were previously treated with ruxolitinib, and 55% of them achieve a response. For the patient that already received ibrutinib, 33% achieve a response. Nevertheless, only 3 patients receive ibrutinib, so it's difficult to extrapolate based on those 3 patients. So when we look at the efficacy by organs and also regarding the Lee symptom scores, as you can see here, if we focus on the patient that receive 20 milligrams, because this is a majority, 40 patients. Here, this is the toxicity. We see that 60% of the patients have some toxicity, but only 30% have some grade 3 or more adverse events. And it was mainly some hepatic toxicity for 3 patients, so it seems pretty safe. Regarding the data, the efficacy per organ that time, as you can see here, regarding the fascia, this is a 50% response rate. For the GI, this is around 40 to 50% depending on the organ of the GI. For the mouse, 33% response rate, and it was more disappointing for the lungs with only 9% response rate. I apologize. So, nevertheless, despite only 2 out of 22 patients with the lung involvement achieve a response, we still have some improvement in the NIH lung function score in 4 patients, but they don't fulfill the criteria for a response. Regarding the Lee symptom scale improvement, we have a median improvement of 4 points. So at least what we aim, this is 7-point reductions that was observed in 41% of the patients. So to conclude, in the phase 2 study, the pimicotinib show good efficacy with an overall response rate of 64% in the 20 milligram cohort, and a good tolerability in those patients with chronic graft-versus-host disease that were already retreated. In both patients with some inflammation-dominated or fibrosis-dominated organ involvement, we have some good response rate that was seen. On most adverse event, and this is the most important, with grade 1 on reversible. So it seems that this highly selective and potent CSF1 receptors inhibitor, pimicotinib, could be a good long-term treatment for patients with chronic graft-versus-host disease, and we again expect to have some follow-up study. So this is what I would like to share with you tonight or today or in the morning, depending on where you are, regarding the prophylaxis and the treatment of acute and chronic graft-versus-host disease. So I don't know if there is some question in the chat. I will be happy. We can take 5 minutes to address some very urgent questions regarding what have been presented. We have one from Dr. Pesic. Hi, Dr. Pesic from Serbia, that ask about the correlation between the duration of antibiotic usage after performing FMT on the response rate. So this is something we need to look more in details. So we know that we have to stop the antibiotics to perform the FMT. And in fact, if you have a patient that receives some antibiotics, for example, for bacteremia, we will wait for a few days until we stop the antibiotics to perform the FMT. But after, we have some patients that may need, again, some antibiotics. So this is why we repeat the FMT, and we have the feasibility to do a new FMT once you stop the antibiotics to restore the response. But we look really closely in details on the interplay between the two things. Regarding the long-term result from Dr. Milan, I don't know if this is in the FMT study. For the FMT, yes, we already have some long-term data, for example, for the ERP, and we know that this is some sustained response because we know that we have some sustained response at day 56, and we have a good response, good overall survival in those patients. So regarding iron overload and thyroid levels in graft-versus-host disease, so we know that iron overload, this is not a good thing after stem cell transplantations. Nevertheless, we have no clear link between graft-versus-host disease. It may raise some issue for some patients that have some liver dysfunction because we don't know if this is some isolated chronic GVHD of the liver, if there is an impact of the iron overload. And in this case, what we always subject is to perform a biopsy to understand what happened. So I don't know if we have some other question. So if you have some more questions, you can reach me on Twitter or email me. Do not hesitate. I will be happy to take any questions. Once again, it was a very exciting ASH. We had a lot of new data in all the field of hematology, and in particular for the transplanter, we are in the field of graft-versus-host disease. The field is really moving. We have some good improvement for the prophylaxis. We have the PTCy now that is well established, and we try to refine the use of PTCy and maybe to combine with the use of ruxolitinib as a prophylaxis. For the acute graft-versus-host disease, we have now the ruxolitinib that is a well-established second-line treatment, but it seems that we may be able to combine some treatment with ruxolitinib, such as GLP-2 analogs, or to have some third-line treatment with the MAD13 microbiota therapy product for patients that fail ruxolitinib, in particular for the GI involvement, but we also see some response with the FMT in the skin on the liver. And for chronic, it seems this is crazy because a few years ago, we don't have any treatment. Now we have ibrutinib, we have ruxolitinib, we have belumosudil, and axatilimab, and some new drugs that are orally available or that combine ROCK and JAK inhibition. So it's truly a field that is moving very quickly, and I am sure that next year we'll see the confirmation of all this study and maybe some new promising drugs. So once again, thank you for being here to share the excitement regarding transplantation and graft-versus-host disease. Thank you for attending the IACH initiative. Just keep posted because there will be a lot of them that will come over the next weeks and months. And I remember you that you can also look at them in replay on the website. So have a nice day and bye-bye.